And now we have the pleasure to invite Dr. Nichols. Dr. Nichols is a neuro-ophthalmologist from the University of Chicago. He's the director of neuro-ophthalmology division at the Cook County Hospital. It's our pleasure to invite him and give a lecture on optic neuritis and COVID update. Dr. Nichols. In Greek.
Μιλώ λίγο μόνο. You don't want it in Greek. Καλησπέρα και ευχαριστώ. So today I'm going to talk about optic neuritis, kind of an overview, and just things that have been happening with COVID. So initially we all know about ischemic optic neuropathy, which I'm not going to really talk about, which is painless visual loss, people with the disc at risk, the small crowded optic nerve, very commonly with atherosclerotic risk factors and ischemic etiology, classically with the altitudinal visual field defect. I'm going to mainly talk about inflammatory optic neuritis with the swollen disc, papillitis, the normal disc, which we see in most cases where it's retrobulbar, and usually a demyelinating process. So I go back to this old study. It's old, but it's still relevant because it's one of the only randomized controlled studies that has really been done in neuro-ophthalmology. So it's still relevant and tells us a lot about optic neuritis. And I go over this every year with the residents just to review some things that haven't changed. And what have we learned? Onset is usually between 20 and 50 years with the mean age of 32, 77% female, 85% Caucasian. Loss of central vision is the classic complaint. People talk about the pure central scotoma, which actually in the study was only found in 8% of cases. Altitudinal arcuate nasal steps were more frequent, and even hemianopic defects. This is from when the paper appeared in the New England Journal. Once again, this was 457 patients, and there were 14 centers in the United States, one of which was with us in Chicago. So these are all the various optic nerve defects that can be found with optic neuritis. So it's very hard to predict just by looking at the field what's going on. Ocular pain in 92% of patients. Ocular pain with eye movement, 87%, photopsias, which are flash, sparks, and other positive visual symptoms, and 30%, often precipitated by movement or sound. And once again, the acuity ranged from 20/20 to NLP, with the vast majority, 20/25 to 2400, was 77%. 11% were 20/20, count fingers, hand motion LP, 10%, and only 3% NLP, and obviously almost all cases associated with abnormal color vision. The study found that in retrobulbar, or in optic neuritis, the disc was swollen only 35% of the time. Disc hemorrhage with inflammatory optic neuritis, 6% of the time, versus the very high incidence which we see in ischemic optic neuropathy. The study also told us that we need to think of other things other than demyelination when there's extreme vitreous reaction, macular or peripapillary exudate. And the study went on for 15 years, and the most potent predictor of MS in the study was the presence of white matter lesions on baseline MRI. And obviously, we looked for the periventricular white matter changes as well as the changes that can occur in the corpus callosum. And that leads to sort of this standard thing that we tell patients, the 25-50-75 rule, based on what their initial MRI showed, a 75% risk of multiple sclerosis with one or more MRI lesions after 15 years, 25% risk of still developing MS if there were no lesions on their first attack of optic neuritis, and was a 50% risk in all patients of the study. So that's important just to tell patients. And we learned these simple things that are now kind of old. IV therapy hastened the recovery, but did not improve the final outcome when measured at 6 months. And importantly, it reduced the rate of development of clinically definitive multiple sclerosis for 2 years. There was a 2-year protective effect, but only for 2 years. Oral prednisone increased the risk of recurrent optic neuritis, 30% recurrent risk versus 13% for the IV group and 16% for placebo. And in general, we avoid oral prednisone unless other etiologies are found, such as sarcoid, which we see a lot of in Chicago. At that point, the recommendation was 3 days of intravenous steroids based on what the MRI showed. And we've learned that the baseline, once again, MRI predicts the risk of MS, although the final outcome not affected by IV steroids. However, the recommendations have now changed with NMO and MOG. From the study, once again, the visual prognosis in general is very good. 93% regained vision of 20/40 or better, with 69% up to 20/20. And once again, the results the same in all treatment groups, even if they got placebo within the study. And once again, optic neuritis occurs in 50% of patients with MS and is a presenting sign in 20%. Other interesting things, male patients or patients who had disc swelling had a lower incidence of developing MS. Other factors with lower incidence of MS were painless visual loss, NLP vision, hemorrhage at the disc, and retinal exudates. But nowadays, in the last 10 years or so, we learned that it's not simply looking for MS. We need to look for other diseases associated with optic neuritis, including NMO, spectrum disease, which gives more frequent attacks and, in general, more severe visual loss, associated with an acute optic neuropathy, which is usually bilateral, can have transverse myelitis with paraplegia, and it also affects the optic nerves and spinal cords and gives unusual brainstem symptoms of excessive hiccups or vomiting. It's usually children and young adults, although any age can be affected. Often the MRI of the brain is normal, but the spine MRI will show changes within several segments of the spinal cord. The spinal tap shows a large number of white cells and does not usually demonstrate the oligoclonal bands that we see typically with multiple sclerosis, more common in Asian and African heritage. So, is it an aggressive variant of MS? It is. The pathology is different. Cerebellum is never affected. There are certain cavities with liquefaction which are not seen with MS. There's an absence of gliosis. And we also have found the IgG antibodies which target the aquaporin-4 protein in astrocytes, which is the test we do, whereas in MS, it's a T-cell phenomena. We also know that standard therapies for multiple sclerosis are less effective and actually may lead to a worse prognosis if you use the immunomodulatory medications commonly used in MS. So immunosuppressive medications are more effective, and with the most common being the start with IV Solu-Medrol, Rituxan, and plasmapheresis if necessary, as well as IVIG in certain cases. In the last couple of years in America, there's been approval for several new medications which are cost prohibitive. The first one is a complement inhibitor, which runs about $700,000 a year. Some of the IL-6 medications are $260,000 and $190,000. Rituxan, which is used most commonly, is about $18,000 per year. So, criteria for NMO diagnosis is the brain MRI, not typical for MS, with usually spinal cord lesions over 3 or more segments, and most importantly, the NMO antibody test, which is about 76% specific. We also now think of MOG, optic neuritis, myelin oligodendrocyte glycoprotein antibody, which is usually in younger people and very steroid responsive. 50% of cases are monophasic without future events. The MRI shows extensive optic nerve enhancement, and it may follow ADEM, especially in young children, acute disseminated encephalomyelitis. post-infection in children where they present with optic neuritis, fever, headache, and characteristically a lot of behavioral changes, which you don't see in cases of MS or NMO. Once again, widespread MRI changes that are not necessarily specific, although diffuse enhancement of the optic nerve is the most typical. Treatment is very similar to NMO. We start with IV steroids and immunosuppression, once again avoiding the immunomodulatory medications of MS. And in general, much better visual outcomes in patients with NMO. So this is kind of an old chart that kind of talks about differentiating the three. MS and NMO have a higher female incidence. Onset less than 11-year-old is really usually common with MOGAD only. Prodromal illness also with MOGAD disease. Optic neuritis with all of them, obviously. Transverse myelitis is very common with NMO and MOG. And then the unusual brainstem symptoms with MS is classically the internuclear ophthalmoplegia, ataxia with MOG disease, and then once again the unusual things with NMO, the post-estrema symptoms of hiccups and emesis. ADEM, once again, very common with MOG. The CSF is slightly different with the oligoclonal bands being very high in MS and very uncommon with MOG and NMO. CSF pleocytosis is variable in all the diseases. We always have to remember, not always these, but other causes of post-viral and bacterial optic neuritis. Usually what we see is post-viral in children, bilateral, may have an associated meningitis and very responsive to steroids. Vaccinations, which we'll talk about COVID. Any vaccination, obviously, from influenza to smallpox to anything can give an optic neuritis. Occurs usually 1 to 4 weeks post-vaccine, which is usually the criteria we use for COVID as well. The World Health Organization you need to have at least a 4-week period to suggest causation. Sarcoidosis and optic neuritis is something we see a lot in Chicago, especially with our large black population, often associated with vitritis, uveitis, and the other common findings of sarcoid. Syphilis and optic neuritis, once again, usually associated with HIV infection. And a lot of HIV patients will have other forms of optic neuritis related to cryptococcus, herpes, TB, syphilis, and fungal infections. Interestingly, we think of vasculitic diseases and other autoimmune diseases. In the ONTT, only 3% of the 457 patients had a positive ANA titer higher than 1 to 320. So the vasculitic diseases are somewhat uncommon as a cause of optic neuritis. And also we think of neuroretinitis in the 3rd to 4th decade with optic nerve swelling with macular star formation, vitritis, and usually self-limited. The classic macular star and disc swelling, which can have vitreal cells as well. 50% may be viral. Cat scratch fever is the classic spirochetes, syphilis, and Lyme, toxoplasmosis, mumps. MS in general is not associated with neuroretinitis. There are several other new paraneoplastic antibodies that we sometimes check for, CRIMP and GFAP, which are now being more studied as causes of neuroretinitis, often associated with other extensive neurologic disease. So back to a case of optic neuritis, we always get an MRI in brain and orbits, whereas before we would wait to see what the MRI shows. We now treat right away, at least we try to, with IV Solu-Medrol, 1 gram a day for 3 days, as well as always ordering MOG and NMO testing. We consider further workup depending on history and other things. And that's partially based on studies that show early treatment with steroids improves visual outcome in NMO and MOG, especially NMO, which has poor visual outcome in many cases. Studies show the earlier start the steroids, the better visual outcome. So we don't wait for the MRI now, we just do our best to get steroids going right away. Now, this is a poster that we presented from County Hospital at Arvo a couple years ago of an optic neuritis. And once again, almost all these things with COVID are case reports at this point. We're still learning the many neuro-ophthalmic disorders associated with COVID. And this patient was a 46-year-old Hispanic male who noted pain with eye movements and decreased vision in both eyes for 4 days after testing positive for COVID with flu-like symptoms. The MRI showed bilateral optic nerve involvement, sort of classically what you see with MOG, and we checked MOG, which was negative. We recommended admission to get IV steroids, but he was a county patient and he wanted to go out back to work. So we started on oral steroids because we really don't know what is correct with this. But his vision improved from 2100 OU to 2020 OU over the course of 2 to 3 weeks. So obviously we're finding COVID can be associated with all sorts of neuro-ophthalmic pathology, including optic neuritis, cranial nerve palsies, and the Miller-Fisher and Guillain-Barré syndromes. Interestingly, there's reports of all these with vaccine and with the disease, but there seems to be almost a 5-to-1 ratio of problems with the illness versus the vaccine. Vaccine problems are rare. There's at least 55 cases in the literature associated with vaccine, and those are usually unilateral cases, and 50% with disc swelling, which is higher than what you see with MS. Interestingly, at least in the case reports, 2/3 are associated with the Oxford AstraZeneca vaccine. Several MOG cases. Remember, viral illness can set off MOG antibody formation, so there's several that are associated with MOG findings, as well as several cases of non-arteritic ischemic optic neuropathy and arteritic ischemic optic neuropathy. So we know that COVID is also, we're finding out, associated with the development or worsening of autoimmune diseases. Several cases of bilateral, actually arteritic ischemic optic neuropathy within 5 days of COVID or vaccine, based on this hypothesis that viral infections can trigger giant cell arteritis and other autoimmune phenomena. And once again, 3 cases of bilateral arteritic ischemic optic neuropathy after the vaccine have been reported in the literature. And obviously, COVID can set off all sorts of ocular autoimmune phenomena: scleritis, episcleritis, uveitis, retinal vascular occlusion, retinopathy. 37% of all COVID patients complain of pain. That's the most common complaint, ocular complaint in COVID patients, and that's without associated ocular pathology. They just complain of pain. COVID and myasthenia, the incidence of onset of myasthenia is higher in COVID patients than the general population. Case reports in the literature range from age 6 of developing myasthenia after COVID to 65, once again, not following the usual demographics of myasthenia, young women and older men. Several reports of exacerbation of well-controlled myasthenia gravis after both the COVID and the vaccine. COVID and Miller-Fisher post-vaccine. Remember, the Miller-Fisher variant of Guillain-Barré is ataxia, ophthalmoplegia, and decreased reflexes. Several cases of full-blown Guillain-Barré, which can be expected, once again, with any viral infection. Cranial nerve palsies have been reported within, once again, 1 to 4 weeks after COVID or vaccine. Cranial nerves 3, 6, and 4, which it seems that number 6 is the most common. MRI studies in general, in many cases, show enhancement of the cranial nerves. Interestingly, COVID and IIH, actually more than many cases in the literature, especially in patients not fitting the usual demographic of pseudotumor cerebri. I personally have seen 3 patients over the age of 50 who are very thin, who developed classic IIH symptoms with elevated spinal fluid pressure within a month of having COVID without the vaccine. And obviously, with COVID, we think of cerebral sinus venous thrombosis And most of these cases are without that thrombosis. And also, there's numerous stroke cases from infarction of parietal, temporal, or occipital lobe with large, hemianopic field defects. Also, reported cases of Horner's, tonic pupil, and once again, almost all these cases are more common with actual COVID infection versus the vaccine. Some of the Horner's cases have been associated with pneumonia, affecting the apex of the lung, respecting the sympathetic course. So, what is the etiology of the COVID pathology? Autoimmune mimicry, inducing an autoimmune reaction is probably the most common thing that's going on. There is probably also a neurotoxic effect of the virus, and we know that COVID gives hypoxia and hypercoagulability, as well as hyperviscosity, which can all lead to ischemic damage to any part of the ocular system. So what about treatment? And the bottom line is almost all these things are based on case studies. More and more information is coming in slowly. In general, though, we try steroids, IV versus oral. Most of the cases of optic neuritis in the literature have been treated with IV, but we really don't know what truly is correct, but steroids seem to help in most of these cases. There's also several reports of complete resolution following the usual pattern of ischemic cranial nerve palsies within 1 to several months. So, in conclusion, COVID and vaccine can be associated with multiple neuro-ophthalmic pathology, but because these are all case reports, causation remains to be proven. The literature is still growing. Every month there's more and more reports in the literature, but it's important clinically to always consider COVID infection and vaccines with any new onset of neuro-ophthalmic conditions. So, ευχαριστώ.